Hi, I'm Professor Andrew Sharp. I'm Professor of Cardiology at University Hospital in Wales in Cardiff in the United Kingdom, and I'm going to be talking today about renal denervation. So there are many systems that control blood pressure, and the sympathetic nervous system is one of them. It's the so-called fight or flight system. It does many of the things that we want if we need a short-term bump in our cardiovascular system. So it puts blood pressure up, tightens blood vessels, makes the heart rate go up. It also causes deleterious consequences if it's constantly on. The idea behind the sympathetic nervous system is it comes on for a short time, then down-regulates again, and we go back to baseline. But in hypertension, there's evidence that people can have a high sympathetic nervous state that is there constantly in the background. And so what that does is it leads to vasoconstriction, left ventricular hypertrophy, renal ischemia, and it activates the renin-angiotensin system, all of which are bad in terms of elevating blood pressure for the long term. So the idea with renal denervation is that we're trying to reduce sympathetic nervous system activity by disconnecting the nerves that communicate between the kidney and the brain and back again. The renal sympathetic nerves are in the periadventitial fat. So in other words, they sit in the supporting structures around the renal arteries. It's not actually within the adventitial renal artery, it's in the fat structures that surround the renal artery, but they are within range. So the idea is that we can pass a catheter into the renal artery, deliver energy through the wall of the renal artery into the periadventitial fat. We heat up the fat, that ablates the renal nerves, and it disconnects the nerves from the kidney to the brain and the brain to the kidney. In many ways, we've got lucky in that renal sympathetic nerves are non-myelinated, whereas peripheral nerves, say to the muscles in the leg, are myelinated. So the myelin sheath that lines peripheral nerves acts as a protector and also a skeleton structure, such that if we disconnect a nerve in the periphery, say to the leg, it is possible for nerve regeneration to occur because it has that myelin sheath skeleton within which to reconstruct its own architecture. The renal sympathetic nerves do not have that myelin sheath. So when we apply energy to the renal sympathetic nerves, we ablate it, we create an interruption in the nerve. That also interrupts downstream nervous function by interrupting the nourishment and blood supply that comes from the cell body upstream. And as a result, we don't just damage the area of ablation, we also alter permanently the function of the axon downstream. So we get axonal loss distal to the ablation site. Because there's no myelin, it's unable to reconstruct along its length because there's no structure along which to regrow. So the non-myelination of renal nerves may be why we're seeing these encouraging durability data. The main device is the spiral catheter. This is a nitinol catheter that is a 4-point catheter. It's designed to form a longitudinal spiral shape inside the renal artery. It has 4 electrodes. The original renal denervation catheter only had 1. And those 4 electrodes will oppose at north, south, east, west at different positions along the renal artery and deliver energy out into the wall. If you put this into a gel model, you get these lovely quadrantic circles where you see a nice symmetrical appearance. But in reality, within an animal or in a human, it's not as simple as that. Energy will run until it's dissipated. And if it's running through and adjacent to different structures, particularly ones that conduct fluid, then that energy dissipates at different rates. You can imagine how, as the energy gets near to, for example, the renal vein, which has a large volume of fluid running through it, some of that energy is carried away and dissipated. So the ablation wave will stop as it gets near to the renal vein. Similarly, there are other structures like lymph nodes that can absorb the energy without the structure being ablated. If you are just running through fat for a fairly long distance, that energy will run for 5, 6, 7 millimeters until it dissipates. Whereas if the renal vein is sitting 2, 3 millimeters away from the renal artery, that energy will dissipate after 1 to 2 millimeters of depth. So as such, we don't get these perfect circles that you see in gel. What we get is this more amorphous structure around the renal artery that is roughly approximating to a quadrant. And we think of it more like a cloud of energy of different depth rather than a perfect circle that forms, or sphere that forms around the ablation point. We've looked at this in a porcine model. We had 2 groups of animals. They all underwent spiral renal denervation, and then we looked at the first group of animals on day 7 and then the second group of animals on day 180. And what we found is that at day 7, as expected, we had necrosis and inflammatory infiltrates in the area where the renal nerves were, infiltrating the area that's been ablated, and then that all resorbs and we get fibrotic infiltration of the area. So what we're getting is a structural filling in of the area where that section of the nerve was. So the ablated area itself, as long as we get it at the time of the original denervation, and of course if you do a partial denervation, and of course everything's different, it may reform its structures adequately. But if we satisfactorily completely ablate that nerve at the site, we get acute necrosis, acute inflammatory response, and maturation, fibrotic infiltration, and basically we have scar tissue that sits in the middle of where the nerve used to be. And so it's providing a durable ablation point as long as we've got it at the time of the original ablation. This is a key point about safety. Of course, we can guarantee that we get all the renal nerves no matter how deep they are just by dialing the energy up. But the energy is being carefully calibrated to give the lowest possible dose of energy required to successfully ablate nerves. There are surrounding structures. So we have the kidney if we go more distally, we have the ureter, we have lymph nodes that can absorb the energy. So it's not like we're doing harm there, it's more that they can make the energy wave at that ablation point less effective. And we have the renal veins. So what we want to do is deliver as little as possible to these structures and as much as possible to the area where the renal nerves sit, which is the periappendiceal fat. So we looked at this on an animal model and we found that depending on where you were within the renal artery, you interacted with different structures, but the dose was so low that we saw virtually no evidence of it at 28 days. So when you looked at the animals at 28 days, it was very difficult to see any effect on any of the surrounding structures, whereas we saw a durable effect in the area where the renal nerves were, which is the goal of the therapy. So it looks like we've got the dose right. The nerves are in a different position depending on where you are within the artery. If you're in the distal renal artery, those nerves are very close to the lumen, and so we've got a very high chance of being able to ablate them there. More proximally, they're a bit further away, and so that's why technique has adapted recently to focus not just on the main renal artery, but to deliver RF into the branches where the nerves are really tightly packed around the arterial system, and therefore we're able to consistently and reliably ablate those nerves and get hopefully a good clinical response. We've recently looked at this in a porcine model and published it in the Journal of Hypertension. What we did was we looked at a cohort of pigs. They all underwent renal denervation. Half of them were sacrificed day 7, half of them at day 180. And the idea was we're looking for an enzyme called tyrosine hydroxylase, the presence of that enzyme. That enzyme is involved in the production of norepinephrine, which is the neurotransmitter used in the sympathetic nervous system at the level of the kidney. If we can demonstrate tyrosine hydroxylase, we demonstrate persistence of sympathetic nerve activity and the ability for continued activity in the kidney. What we found is that at day 7, there was a significant reduction in the volume of tyrosine hydroxylase as measured by staining for that enzyme. And then we looked at day 180, and again, there was similarly minimal evidence of durable tyrosine hydroxylase presence, and therefore the ability to manufacture norepinephrine and produce persistent sympathetic nervous activity. So that's one way of looking at durability in an animal model. Is the enzyme present that can produce the neurotransmitter that activates the sympathetic nervous system in the kidney? And we're pretty confident that at day 180, we've seen durable reductions. The other way to do it is to pulp the kidney and look at the renal norepinephrine concentrations in the renal cortex. So do you have the end product of the sympathetic nervous system, norepinephrine, within the pulp of the kidney itself? So we see appropriately high levels at baseline, then we denervate them. At day 7, we see a significant reduction in renal norepinephrine, and then again out to day 180, we say similarly low low concentrations of renal norepinephrine. So it does look like we've got it. The dose in the IV study that was achieved by denervating the branches in the main was about a 92% reduction in renal norepinephrine. We don't get every single nerve and we don't need to, but we are significantly reducing that concentration of neurotransmitter at day 7 and at day 180. And it seems anatomically and physiologically implausible you'd subsequently get a rise in activity afterwards, and the human data support that. So the major landmark trials had to report it between 2 and 6 months because we had to get patients with uncontrolled hypertension back onto drug regimens. Those were the rules set by regulators and by ethics committees. But we do have a way of looking at longer term effect. So we got 2 ways. We got the original on-med RCT, which we recently published in The Lancet in 2022, showing that out at 3 years, even once you'd added medicines on to both groups, the sham group and the denervation group, you showed that there was a significant disparity in blood pressure lowering that favored the group that had had denervation. We were also able to see an 18.4 out at 3 years with a combination of denervation and drugs. And then in drugs alone, that was 8.6. So the difference between the 2 groups was about 10 millimeters of mercury on ambulatory blood pressure monitoring, quite a stringent way of looking at high blood pressure. Now, at 6 months in the original on-med study, we saw a 9-point drop in ambulatory blood pressure. At 3 years, we're seeing a 10-point difference between that and the control arm. Now, the data are not quite the same because patients have had drugs added, but actually, the patients in the denervation arm had fewer drugs numerically than the patients in the sham arm. So what we're seeing is a greater blood pressure fall in the denervation group that's consistent and durable out to 3 years, despite fewer drugs compared to the control arm. So it's reasonable data, it's supportive data, but we need more. We therefore look across at a large-scale registry that's recruited up to 3,000 patients, which is the global Symplicity registry. And we've reported 3-year data on those. And what we see is it's a single arm, obviously it's a registry, is blood pressure comes down by about 12 to 14 points, and then as it goes out, it at least stays durable. In fact, there may be a signal of progressive blood pressure lowering over time, which could be multifactorial, but nevertheless, we see no evidence of a loss of durability. And finally, Professor Schleich and Professor Essler from Australia have recently released data at the European Society of Hypertension in 2022, looking at their original cohort of renal denervation patients that they treated with the original RF catheter. And they've shown durability of blood pressure lowering effect out to 10 years, which was a real surprise because I personally expected age-related return of high blood pressure. Blood pressure goes up with age. And so the fact that there's a durable effect demonstrated out to 10 years, admittedly in a small single-center cohort, again, gives further support to what we've seen in that preclinical data. Those preclinical data suggest it isn't possible to reconstitute a fully ablated renal sympathetic nerve. And so the human data are beginning to show evidence that supports that.